Alright, this is Nursing Care of the Growing Family. This is mostly skin, genetic, and mobility disorders for Unit 7. So here are just some of our objectives. Okay, so integumentary system. These are several different integumentary disorders that we can see with our patients. Lice. These are white eggs firmly attached to the hair shafts. Scratch marks, papules, pruritus is typically seen. We're going to put in a pediculicide or a specialized shampoo and then manually remove the lice and nits with a metal nit comb or a very fine tooth comb. This is going to spread via personal items, and it does not matter whether you are a clean person or a dirty person. In fact, the nits sometimes prefer the clean hair. Scabies is an intense itching. We may not see symptoms of scabies for 30 to 60 days. So you may be infected before you see symptoms, and then you'll see eruptions. We treat it with scabicide, eliminate, and it may take a couple weeks, like 2 to 3 weeks, to relieve that rash. Impetigo is a reddish macule, ruptures easily, sharply marginated, irregular outlines, has honey-colored crust and pruritus. Basically, what we do if a kid has impetigo, we're going to do good cleanliness, and we're going to put a topical bactericidal on it and possibly some systemic antibiotics. Ringworm, we see typically when we are in dirty situations or sweaty situations such as wrestlers. There's not a whole lot we can do, but to prevent it, we need to make sure we're cleaning things well. Herpes zoster or herpes simplex. These are, zoster, as you know, follows the nerve. It's pain and itching. With symptoms, we'll be doing, we'll just treat the symptoms. So pain meds, moist compresses, acyclovir, lidocaine. If it's for simplex, you're going to have a burning, itching, dry crust, and you could do acyclovir, Valtrex, something along those lines. Acne. This is due to sweat and those sebaceous glands typically getting plugged up with dirt and grime. We are not supposed to pinch or pop zits. Basically, it's a matter of just really cleaning. Chicken pox we've talked about. Once you've had chicken pox, you're kind of high risk for, developing like herpes zoster, shingles later on in life. Fifth disease we've covered, rubella we've covered, and rubeola we have covered. And infantile eczema, Basically what we're doing is we're just doing good cleaning. We don't pick at it. We want to try to keep the skin somewhat dry. We may put some moisturizers on it, but it's not necessary. Just make sure we're doing good cleanliness and we're not touching it tons. This we'll discuss in class, hopefully, but what do? The parents need to get rid of the head lice. Basically, we are going to treat their hair with the specialized shampoo. We need to get rid of anything that could have live hair on it. Good cleaning of the blankets and the bedding and things like that. These kids will still go to school. You're going to follow the directions on the bottle for the cleaning of the patient's hair, but it really does take tons of time of combing through the hair and picking out the nits and getting rid of the bugs themselves, because that is the biggest goal. whatever doesn't get killed and removed by the shampoo, and then we need to go through with that fine tooth comb and get rid of the bugs. And it takes a long time, and it can be painful to the child, but it needs to be done, because if you don't get them all out, they're just going to keep coming back. This is just a picture of impetigo. So I know, don't you want to like pick at it a little bit and stuff, but we just leave it alone. Here's some more pictures of impetigo. Chicken pox, fist disease, so just some reminders for you of these. Rubella, rubella, scabies, ringworm, okay, so hopefully we know how to treat acne. Basically, there's many things you can do. There's lots of over-the-counter face washes that help with the removal of the clogged pores. Some kids end up having severe acne, and they need to go in and get more of a prescribed medication to help with the acne. We don't want to be picking at it. We don't want to be touching our face a lot. That helps get rid of it. In fact, wearing tons of makeup also does not help with acne, because what is it doing? It's just clogging up those pores. So when we are wearing makeup, we need to make sure we are cleaning our face regularly, and then making sure that we are not touching our face tons in between throughout the day, and making sure that we only use our makeup for the so many weeks to months, because they get dirty, things like that. Okay, you should be able to answer this question, and you should be able to answer this question. Down syndrome. Okay, Down syndrome is a genetic issue. With this part of the PowerPoint, you should be able to describe the nursing care management, describe ways to support the family, figure out ways to prevent physical problems, and then know how we diagnose it in genetic counseling. So Down syndrome is has some very specific characteristics. You can see some of it in this picture here. They have the slanted eyes, and they have that depressed nasal bridge and those low set ears. They have a protruding tongue. They also will have hypotonia and hyperflexia. And they will have, with their protruding tongue, it sticks out a lot and can cause some speech development with them. It also affects their feeding as well. Some other things we may see common with our Down syndrome kiddos is they have a shorter stature, small mouth. Their palate and their mouth is extremely arched, so it may seem higher than normal. Short, broad fingers. They tend to have a simian crease on the palm of their hand. A short neck with extra skin at the nape, so that almost like a buffalo hump. They can have epicanthal folds on the inner corner of their eyes. They sometimes have extra space between their large and second toe. Their eyes turn slant more upward, if I recall correctly. Yeah, an upward slant to their eyes. What do we do for these families? When we know about it before birth, we are going, and even after birth, we're going to do tons of genetic counseling. We are going to work on the feeding concerns with these kids. So they may have some failure to thrive. They won't eat as well. It may be very difficult to feed them. Their skin tends to crack and dry easily. So we'll teach the parents good ways to take care of the kid's skin. They can have cardiac issues. They can also have thyroid issues. So we'll do tons of screening related to their cardiac system and their thyroid system. They, respiratory-wise, they can be compromised and they're at higher risk for upper respiratory infections. This is a chromosomal abnormality that occurs in, approximately 1 in 800 to 1,000 live births. Typically, we see it with advanced maternal age. They're saying moms that are giving birth at over 35. And then at over 40, the risk goes up. I have also seen it very common for Down syndrome to occur in those super young parents as well. So when we take care of these kids, we're going to get cardiac involved. We are also going to need to get a number of other therapies involved. Depending on what congenital anomalies they have going on, we're going to do surgery to correct those as well. These guys can also have sight and hearing issues, so we're going to do a lot of evaluation of their hearing and their eyesight. So this family is not going to just have this basic care. We're going to get a lot of people involved, from genetics to OT and PT and speech therapy and cardiac assessments, thyroid assessments, all sorts of things. We're also possibly going to get like the Centers for Disease and Disabilities involved so that this patient can qualify for more assistance. Our big thing as nurses is to support the family at the time of diagnosis and then help them with this preventing the physical problems. So teach them what we can and help ensure that they understand how to take care of their kids and become those experts. We may even have them go through specific genetic counseling to make sure they don't have a family history of Down syndrome, or to see if there's like a higher risk factor for having more children with Down syndrome. A lot of the times when we don't know about this before birth, it's going to be those parents that have poor prenatal care, and those babies are going to be at higher risk for that failure to thrive. These kids can be on all different levels of cognition as well. So I've seen some Down syndrome kids be very self-reliant and be able to basically live almost on their own and hold some basic jobs and take care of themselves. But then you have those kids with Down syndrome that are going to be very low functioning and need a lot more assessment. So when we're taking care of these kids, we have to look at each Down syndrome patient specifically for what they are cognitively, so we can teach them appropriately. Okay, so strabismus is the when you see a kid that's squinting or having trouble focusing, they have poor judgment at times, they can't see print clearly, they close one eye to see or tilts the head to the side, photophobia, dizziness, headaches, cross-eyed. It's all going to determine on how bad the strabismus is on the treatment. A lot of the times they will patch the weaker or the stronger eye so that the weaker eye can do a lot more work. Conjunctivitis is that redness, edema, tearing, discharge, eye pain, and itchiness. I'm sure we've all dealt with it at one point or another. Basically, we're going to treat it with antibiotics and warm compresses, especially if it's bacterial. A lot of the times they'll isolate these kids for 24 to 48 hours. If it's viral, we're just going to treat the symptoms, and if we think it's related to allergies, we'll make sure they're getting antihistamines. Another thing with conjunctivitis, besides doing the warm compresses, I like to do some lacrimal massage because that's going to help, if anything's clogging the ducts, help break that up. Amblyopia is basically poor vision or a lazy eye. Basically what we're going to do is we're going to prevent visual defects. So if it's a strabismus, we're going to patch that good eye for a couple hours a day. We may do atropine drops. They may even do surgery to fix this type of an issue. Okay, so hopefully in Foundations 2 you've gone over some mobility things. We just got to think about how immobility is going to affect that child differently than it might affect an adult. It may limit their function, of course, but they could potentially delay their milestones. Okay, so we may have some major consequences after immobilization, and they may not reach some of those other milestones as easily as their peers. Just like an adult, they're going to have decreased muscle strength and endurance, which could take weeks and months to restore. They could end up with bone demineralization, so they could be at high risk for osteoporosis or pathologic fractures, and that can lead to growth and developmental issues. Due to the decreased mobility and contractures, those muscles and tendons and ligaments, they can shorten and decrease joint movement. They could be at high risk for contractures. Psychologically, these guys are going to need to be able to vent their anger. So we're wanting to get them to talk about their feelings and impulses. We also want them to figure out ways to control what is going on and help them deal with any anxiety. Decreased stimulation, so they may not feel, touch, sight, hear, taste, smell as well because they are isolated and bored and they're disconnected from their peers. So what can we do to help them with that? Can we do Skype with their peers? Can we make sure friends come in and visit them? Can we get them involved in different activities? They're going to have feelings of helplessness and depression. They may actually act out to seek attention, and we may see that protest and anger that is going on, and kind of think what happens in those protest stages and those anger stages depending on how old that child is. So if they were potty trained, they may start bedwetting, or they may want you to provide more of their cares and feed them. They may have more crying or temper tantrums or things like that. So when we have different types of bone fractures, you have that green stick, you have a spiral fracture, the communid fracture, transverse, and compound. When a child is having mobility issues, we want to make sure we're doing frequent repositioning because it's going to prevent dependent edema, stimulate circulation, help with the respiratory function, help with GI motility and neurosensation. We're going to want to make sure we're keeping them well hydrated and encourage as much activity as possible. We're going to increase their protein and increase their calories and vitamin B and C for the healing process. We may distract them, allow them to get through their anger depending on what's going on with their fracture. Make sure we get them out into visiting their friends and going out into the hallway and getting them involved in as much as their care as possible. Have somebody help them with their schoolwork. let them choose what they eat. Get them involved as much as possible. This is what's really interesting about immobilization and bone healing. Babies or neonates that have had a broken bone, they can repair themselves within 2 to 3 weeks. That's because they have a thick periosteum and generous blood supply. Early childhood, that same fracture may take 4 weeks, and then later in adulthood, that same fracture could take 6 to 8 weeks, and in adolescent, 8 to 12 weeks. And then as we know in adults, we end up being those longer time periods as well. One big issue with these injuries is where it occurs. So if it occurs on that epithelial growth plate, that's one of our weakest points on the long bones, and that's where our bone is continually growing. And if there's a fracture through that, that could affect that child's growth. What they may do is reduce it, and realign to regain length. Okay. Here's a good little cartoon on traction. This is also a nice concept map on what we do when there's a child with fractures and how to take care of that child, and ways to write that location accurately. Okay, scoliosis is something we also see a lot in our pediatric population. It is no longer screened for in school because it was easily misdiagnosed. What is going on with scoliosis is we have a lateral curve or spinal rotation of the thoracic hypokyphosis. It's a very common spinal deformity, and we see it typically during that growth spurt. We don't always have a cause, but if there's a severe curvature, that can cause respiratory and cardiovascular issues. We are going to diagnose with x-rays and measure that curvature. Some kids will end up with a brace, and that just slows the progression of that curvature, but it does not cure it. Some kids will end up with a spinal fusion, and that will just fuse it in that straight pattern. When we do spinal infusions, these kids aren't going to be able to flex or extend their back, so we're going to have to do log rolling with them. They're going to be very high risk for significant blood loss. We're going to have to do tons of neurovascular checks as well. Torticollis is poor neck movement and range of motion. This could be due to plagiocephaly or asymmetric head cranial molding. That sternocleidoid mastoid muscle tightens on the preferential side, and therefore it tightens and it just kind of holds that head off to the side. So what do we need to do is tons of exercise to loosen that tight muscle. We're going to switch the head position during feeding, carrying, and sleeping. Once again, we're going to encourage back to sleep and alternating the head placement and do those muscle exercises. So we need to make sure we are putting these kids on their bellies so they start raising their head of the bed up. Making sure that they are, when we're lifting them up and they're learning to do that head control, that you let them control the head and move it lightly. Things like that. Okay. You should be hopefully able to answer this question. It is kyphosis. Okay, so what signs would indicate compromise in the extremity? Pain, swelling, discoloration of those exposed portions, decreased pulses, decreased temperatures, or inability to move the exposed parts. Okay, CP or cerebral palsy. We should be able to answer all of these after I'm done with the next few slides. So cerebral palsy is characterized by early onset, impaired movement and posture. They end up having abnormal muscle tone and coordination. It's non-progressive. It may be accompanied by perceptual problems, language deficits, and mental impairment. It occurs in 1.5 to 3 persons per every 1,000. They say one of the causes of cerebral palsy is anoxia, secondary to other causes of mechanisms, which leads to that brain damage. So is it due to prenatal, perinatal, and postnatal factors? Existing prenatal brain abnormalities more often cause the cerebral palsy before asphyxia. Perinatal would be birth asphyxia, maternal infection, things like that. However, that birth asphyxia, I've been reading lots of research on that saying that it is typically due to not the asphyxia that's occurring during the delivery, but they probably had some asphyxia before they even got that far. Postnatally, prematurity, because of their brain being so sensitive to bleeds and damage. Low birth weight, things like that, because those kids are at higher risk for damage to that brain. We have a couple different classifications. Spastic or hypertonicity on one or both sides. That is increased tone and tension in the muscles. They have a stiff, rigid posture, and then they have difficulty with coordination and balance. Dyskinetic or athoid is abnormal involuntary movements. They have like a worm-like, slow type of movements. They drool, and they have issues with their speech and articulation. They end up having a lot of jerky movements, especially when they are under a lot of stress. We also have ataxic types of CP. They have a wide-based gait. They perform rapid, repetitive motions poorly. We have mixed dystonic, and that's a combination of spasticity and apoptosis. So delayed growth motor skills is one way that we notice that these kids may have CP. They also have those abnormal motor preferences, so difficulty with fine and gross motor skills. These kids may also walk on their toes, like tiptoes, related to hip adductor contractures. They may have poor sucks, feeding problems, and drool a lot. They also may have an asymmetric crawl. With their alteration of their muscle tone, we're going to see that stiffness and rigidity. We also may see abnormal postures, so like scissoring of the legs, persistent infantile sleep posture. With reflex abnormalities, we're going to see persistent of those primitive reflexes, so asymmetric tonic neck reflex or a persistent Moro reflex past that 4-month mark. Hyperreflexia, so those reflexes that are hyper-responsive. Other disabilities that we see with CP is subnormal learning and reasoning. 2/3 of these kiddos tend to be mental retarded. 40% will have seizures, and a bunch of them will have sensory impairments from visual deficits to hearing problems. So how do we help these kids? Well, early detection is good because then we can, by monitoring and knowing what their developmental milestones are, then we can get that therapy going sooner. So we're going to involve OT, PT, and maybe even some speech therapy to help with activities of daily living. We're going to establish locomotion, so we're going to start doing braces early. That may help prevent deformities or increase the efficiency of their gait, may help control that alignment that is going on. We also want to provide them with incentives or reasons to move around and continue to do range of motion exercises so they're not developing contractures. We're going to encourage them to groom and dress appropriately for their age, and that way they have good self-esteem. And then we're going to do correct those associated defects. So if they're having visual defects or hearing issues, we're going to get like speech therapy and OT therapy involved to help with that. Lots of education for the parents and the child, and we're going to keep that child socialized. If they're having muscle spasms, they may have pain with that, so we may end up doing like pain therapy for them. If they do have contractures or spasmodic deformities, they may end up having surgery to fix those. 53% of cerebral palsy patients are able to work with a regular job. Meds will do some that will help with muscle coordination. We may do baclofen pumps for that spasticity. If they have seizures, we may do anti-epileptic meds. We may use biofeedback. We may even, if they have severe speech problems, do those computerized devices. We're going to do close monitoring of their feeding, teach the family how to do that skin integrity, and watch their movement and skin related to braces or any assistive devices they are using. Some of these kids can have very normal lives as long as we give them the therapy they need. These guys will also probably be involved in like Centers for Disease and Disabilities as well. Okay, hopefully you guys can answer this question. The answer is A. The answer to this one would be D. Adulthood or early adulthood. There is no pathologic picture. Okay, so poor head control after 3 months of age, stiff or rigid arms and legs, pushing away or arching of the back, floppy or limp body posture. They're unable to sit up without support by 8 months of age, and they may only use one side of their body or only the arms to crawl. Okay, you should be able to answer this question from the neuro PowerPoint and from health assessment. So some goals of nursing care for children and families with cerebral palsy: recognizing it early, increasing mobilization, educate and socialize. And you should be able to answer this one. This should be a review from health assessment as well. So B. The Hib vaccine, HIB, and that